I'd like it if you could start, Carl, going as far back as we can go, and talk a little bit about what it was like for you right at the beginning of your career in psychotherapy as a psychologist at that time.
Well, I remember that a psychologist whom I respected very much was quite concerned that I was thinking of going into counseling and psychotherapy, because he said a psychologist will never be able to do that. That's a medical field, and you'll just run into a lot of frustration. You won't be able to do what you want to do. And I was really concerned about that. But I'm afraid I went ahead anyway. And I think one of the things that, one of the sort of stealthy aspects of my career is that I felt we wouldn't be permitted to do psychotherapy, so we focused on counseling. But we did so much research in counseling that finally people had to admit we were doing therapy. And so little by little we gradually gained some foothold in the field.
What defined therapy? I mean, what was the dividing line between therapy and counseling, really?
To my mind, there really is no sharp dividing line at all. I think we use therapy more often if the problem is deep and persistent, and the person has to work at revising their whole personality. And we use counseling usually for lesser problems, but I don't think there is any dividing line. I think one shades into the other.
What kind of people were you seeing at that time?
Well, I began to get some of these ideas when I was in Rochester, and that there I was working with children and their parents mostly, and working in cooperation with social workers and so on. Then when I went to Ohio State, the ideas developed further, and I think it was at Ohio State that we brought Otto Rank for a weekend workshop, and I really liked his ideas about therapy. I used to joke that I didn't like his theory, but I liked his therapy. And then one of our staff members was later analyzed by Rank and wrote me at great length about it. So that was an influence in my life there.
Because your training was pretty much psychoanalytic, wasn't it?
I'm sorry?
Your training was pretty much...
Yes, well, it was two very divergent things. At Teachers College, Columbia, it was all very statistical. Everything was measured and not much. And I remember one of the faculty members saying, "You talk about emotion, there are no such things," or that wasn't important at all. And then at the Institute for Child Guidance, the other half of my training was deeply psychoanalytic, and all the psychiatrists were psychoanalysts, and the psychologists, many of them had analytic training. So,
when is it that you start noticing that you are kind of diverging from your...
I really have always felt that I was just voicing what everyone thought. The point, and I went, I think, a long ways in that, the point where I became sharply aware of the fact that I was doing something different was in December 1941, I guess, when I was invited up to Minnesota to talk to the Psychi, which is the honorary psychological society. And I think my talk was on newer concepts of counseling, something like that. It was the stronghold of Williamson and Darley and the testing approach and testing and advising approach to counseling. And the first part of my talk was devoted to outmoded methods of counseling, in which I listed advice and persuasion and manipulation and I don't know what all else, suggestion. And I gave a couple of examples of that from the literature. It turned out that one example that I gave was actually a case worked on by the graduate student who was chairing the meeting. And after I got through giving my talk and giving some of the newer ideas that I was developing, there was just a furor of discussion and questions and attack and agreement. And I realized, hey, I'm not just speaking for everyone. I seem to be saying something quite new and different.
Mm-hmm.
I think it was at that point that I determined to write a book.
What were some of the issues at that time?
Well, they were strong proponents of measuring everything about a person by psychological tests and then telling him what he was best fitted for and how to solve his problems and what career he should go into. I know the case that I cited that had been done by the graduate student who was chairing the meeting was one in which his report started out, first of all, I will have to dissuade this person from the major that he's taking and get him into something else, and then, I don't know, it was a prescription for his life. It was very strongly prescriptive. And the scorn which they felt for a non-directive kind of approach, which was what I called it then, was very strong, because they felt certainly the patient, the student, whatever, couldn't possibly know what was best for him or what were the answers to his problems.
Well, didn't the clients at that time also expect that the professional, the doctor, was going to know what was best? And
not only at that time, but even down to the present.
Even down to the present, yeah.
Yes, certainly that was true. And at that time, I know when I was working in Rochester, and to a lesser extent at Ohio State, it was regarded as a quite shameful thing to have to go for psychological help, after all.
Mm-hmm.
You kept that quiet. You didn't let people know that you were going to see a counselor. It would mean that you were a little bit crazy or something.
But in the meantime, since that experience in Minnesota, many changes must have taken place in the field as a whole, and also in your own work.
Many, many changes. I know when I wrote my first book in counseling and psychotherapy, the prospective publisher wanted to know what courses would use that. And I said, I hadn't thought of that, but I would use it in my courses, and I knew one or two other people that I thought would use it. And in spite of that, they finally decided, when I threatened to take the manuscript away, they decided they would publish it. And then, that was in end of 42, and as the soldiers kept coming back from the war, and by the end of the war, the need for counseling was apparent to everyone, so then it was a flood of counselor training. And what books were available? Well, not very many, and mine was one of the few.
Mm-hmm.
So that's what that meant, a tremendous change in the public attitude and in the need for counseling and therapy and so on. The servicemen returning had many problems and needed help.
One of the changes that I think it happened, Carl, that you mentioned non-directive approach, and you said that's the way I called then.
Mm-hmm.
And I think my impression that you are much less non-directive than you used to be, but sometimes I still hear people describing your approach as non-directive, and using interchangeably with person-centered. And I wonder.
Well, it's non-directive in the first place was a protest, because all counseling at that point was directive. You directed the person on what they should do. And so it was a statement of what we were against rather than a statement of what we were for.
Yeah.
And then as we realized that, well, let me pause a minute there to say one of the big issues was that I called the people who came to me clients. And psychiatrists in particular thought that was ridiculous. And nobody liked it very well, including myself. I just don't know a better word. But at least it did indicate that this was a responsible person coming for help, not a patient, not someone who must be directed. And so we gradually came to use that term more and more, and then thought, this is a therapy that's centered in the client, where the client is the responsible person, and so that led to the use of the term client-centered. And then as it became, as this approach began to spread into the fields of education and family life and business, That wasn't therapy at all. So client-centered didn't fit. And so gradually we've come to use the term person-centered approach, because it isn't always therapy, it's different.
I remember Ronnie Lang talking about what really struck him right at the beginning about your work, and he gave that story about how when he started, the patient was behind the desk and the therapist was at the other side of the desk, the good doctor was at the other side of the desk, and it was quite clearly a patient and a good doctor, and that what you did was you sat face to face with your client and changed the name, and I remember him being so clear that was a really profound change in the whole power relationship between the professional and the client. And it seems that that's central to the whole work.
I think that power issue still exists today, that many therapists find the way that I work not at all congenial for them, because they're accustomed to being the person with the power in the relationship. They have the authority. They're the ones who are the experts. And they can't imagine themselves relinquishing that authority. So that was not only an issue then, it's still an issue.
Why do you think that is? Is that part of the education and training, or the mindset of the people that get into it? Or the patients demand it? Or?
To some extent, the people coming do demand it, and therefore make themselves patients. I think, too, that people have more of a need for power than we tend to recognize. That's true in schools. That's why it's hard for teachers to adopt this approach to learning. They really feel a need to be powerful in the relationship.
Well, it really is. The temptation is very great to want to take that power position. You're with a person who's hurting, who's can see no way out at all. They're in the middle of the confusion of their whole life, and it's very tempting to have words of wisdom and to assume that what's worked for you or other clients will work for this person. And at least initially in my training, it felt almost like I was withholding, not to give advice and not to take over the problem for the client. So I think there's a lot of persuasion about the situation that makes it very easy to pick up the power and very difficult to let it go.
That's right.
But I also had seen the opposite happen. Like the therapist becomes so powerless. They sit there and they become so passive. And that, for me, it's not what you're talking about. It's a shared power where two people are there present. And
that's good. Yeah.
And I think that sometimes your approach is confused with passivity on the part of the therapist.
I think that that's definitely true, that many people think of it as a way of working with individuals that is passive, it doesn't take any active part. That's one reason why in the last few years I've done more and more demonstration interviews in front of groups, because then they realize, oh my God, this is a very active process in which both people are active, and active in a very unusual way. Because the way I like to do therapy, I want to be so intensely into the world of my client that I just can feel what it's like, and I want to be a companion to that client in whatever feelings he or she may have, even though they might be despairing feelings or feelings of worthlessness or whatever. I want to go just as far as the client feels that feeling, and be a companion to him or her, so that they know that it is not so fearful. It's not so fearful to be despairing. It's not so fearful to be worthless. And once they realize that, they can face the feeling, experience it, and begin to walk out of it.
That's very different when the psychiatric experts sitting outside the situation and advising in regard to it?
I think very few people realize the extent of that difference. It is a tremendous difference. The polarity between the usual psychiatrist, particularly, that a person might go to see, and a really person-centered therapist, I think is tremendous. I think the difference is really, it's impossible to exaggerate. And yet people sort of class us all together. I mean, and I don't think we belong together. That's one aspect of that is that we've moved away completely from the medical model. The medical model is you study the individual, you diagnose, you prescribe, you carry on the treatment, whether that's drugs or physiotherapy or hospital care or surgery or verbal interpretation. And we really reject that completely and go for a growth model that if the person is in psychological difficulty, then that must be because of some influences that hampered his or her growth. And who can find what those are, and who can find what to do about it? The client can, if he or she feels safe and free in a situation, free to express everything that he dares to express. So we help the person to grow past his difficulties rather than imposing treatment on them.
Do you ever find in entering into the experience of the person that you're feeling lost and that you're not sure if you're helping?
It occurred to me once in very extreme form where I really lost myself in the world of the client, and I do not recommend that experience. I felt that I was really going over the brink into a psychosis. It needs enough maturity on the part of the therapist that the therapist can leave behind his world and get into the client's world, but know that he can come back to his own world.
I think of it as a word that I keep resonating is intersubjectivity, that the doctor-patient doesn't really have that kind of, another word is dialogic relationship, and it's even taught to not have that kind, and where this clearly asks for that.
That's right.
And it's like, but it's, the interesting thing is it seems like you in a sense followed your clients in that way. In the years that you've developed this, they're asking for that. Something about their asking for that evoked in you, the therapist, the deepening awareness of the significance. But they didn't ask for your identity, like when you said you went into a borderline psychosis state. Something about that you seem to learn that what they were you made a distinction between, they weren't really asking for Carl Rogers per se and his life and all of that and his identity, his own identification, but they were asking for his presence.
Yes.
And in that presence you can go as deep as you want to go. But that, I guess I'd like you to talk a little about the distinction, but and you use your words, of course, between, say, your presence and identification.
Well, I think presence is one of those fairly simple terms that when you get into it is very, very complex. I think it's terribly important to be fully present to the client. What does that mean? I think you've partly defined it yourself, that it means that we're very closely connected on a subjective basis. But it doesn't mean that I pour my life into the client or that the client pours his life into me. It means that we enter into a close communicative relationship in which we both are experiencing much the same thing. I've thought that in the best moments of therapy, I think we're both in a slightly altered state of consciousness, that we know more than we know. That has impressed me, that in the best moments of therapy, my organism knows things that my mind hasn't grasped yet. And that's very, again, that sounds almost mystical, and in a way the experience does come close to being a mystical type of experience in the best moments of therapy.
And it's mutual. I mean, the client will experience the same thing, that they know in the state more than that they know.
That's right.
And that's where they're getting the new possibilities from, which is part of their growth.
It's a mutually altered state of consciousness.
Don't you think that that connection is that the I-thou relationship that you and Buber kind of discussed about, where the hyphen is what's really important. The I and the thou are kind of lost their own identity.
I might add a personal note there about Buber. I once had the opportunity to have a face-to-face dialogue with him, and it was a very good dialogue. We shared ideas and felt in fundamental agreement and so on, except on one point. And that's when I said that in the deepest moments of therapy, I said, it really is your I-thou relationship. And he said, oh no, that couldn't be. And then to finally clinch the argument, he said, certainly with a psychotic individual, you couldn't possibly have an I-thou relationship. With a schizophrenic individual, beg pardon. And I said, just yesterday, I had such an interview with a schizophrenic, and it was very much an I-thou relationship. Well, he couldn't, we just disagreed on that. Then I saw him the next morning at breakfast, and he'd still been mulling that over, wondering how I could be so mistaken. And as we talked, I learned that his courses in psychiatry had been taken somewhat before 1900. He was thinking about dementia precox, and that the mind of the schizophrenic was actually inferior, and so it must be that I was on one level and the schizophrenic on another level, and he couldn't imagine that we could meet as equals. That's one thing too about this power thing. In the kind of therapy I like to do, we meet as equals. This may be a person with no education or very few credentials of any kind, but nevertheless in that relationship we are equals.
When we were discussing the preparation for this program, one of the things we talked about was that meeting as equals, that this is not only a theme in therapy in your work, but it's been a theme in education, and it's currently, and we'll get to that later, a theme in more global relationships and so on. And it's that meeting as equals that makes it so radical. And it makes it radical in families, and it makes it radical in the classroom, and it makes it radical in healing, and I think it's what immediately impressed me and attracted me about your work from the very beginning. Looking for a way to be in the classroom where we would meet as equals, and at the same time where I could be present with all that I knew, which was more at that time about biology than my students did. But I didn't know more about what they were interested in than they did. And so this has been a theme, I guess, for my interest in the work all along, is this meeting as equals. And I stub my toe on that one, whether I'm at home with my family, or I'm talking to my mother, or I'm with clients, that it's not, it's quite a challenge.
It is.
It's quite a challenge.
It is. And as you say, it really is a revolutionary point of view. It takes almost all of the traditional relationships and changes them in a very radical way, whether we're talking about, as you say, marriage or parent-child relationship, or teacher-student relationship, therapist-client relationship, employer-employee relationship. Whenever people take this philosophy, because it really is a philosophy more than a method, it tends to turn their lives upside down. I used to tell my graduate students, if you get deeply interested in what I'm doing, that's going to cause you one hell of a lot of trouble, because you'll be seen as radicals. People will not like what you're doing. Outsiders will not like what you're doing. The people you're dealing with will like what you're doing. But
it sounds like a notion that's easy to adopt for the person that's in the traditionally superior defined position, that they can enter into the equal relationship. But for the person, the student, or the child, or the employee, to try to make that kind of relationship could lead to tremendous resistance and
Yes, that's right.
complications.
And that's why one thing that I've often said is that this is a point of view which can be, you can permeate whatever situation you have responsibility for, but it's very difficult to make it work up the ladder. Students can't cause their teachers to be student-centered. Employees can't cause their employer to be employee-centered.
But don't they have to?
And we need to break at this point,
Okay.
and I think that seems like a good end the theme, that it's this meeting as equals and the difficulties that are encountered in that. So maybe we can pick that up.
Yeah,
Next,
maybe we can pick it up.
Yeah.